We have our first guest speaker. We have Mr. Karlin Bacher, the Director of Clinical Quality Improvement in the Jericho Road Community Health Center, which provides clinical care to underserved communities in the United States, Sierra Leone, the Democratic Republic of Congo, and Nepal. He's also a registered nurse with the experience of emergency nursing, global health, infectious diseases, population health, and quality improvement. Today, he will share his insight on using technology to leapfrog gaps present in global health. Hello, Karlin.
Good morning, good afternoon, good evening. Thank you very much. About 17 years ago, I started my healthcare journey, first as an ER tech and medical first responder, and later as a registered nurse in a busy US-based emergency department. It was a significant day when administration rolled the first portable ultrasound machine into our emergency department. As you can imagine, the response uptake from the emergency physicians was mixed. Some started using it immediately and frequently, especially as we treated our trauma patients. In my role as a charge nurse, I was often called upon to start difficult IVs in the patients we served. I started eyeing this new ultrasound machine. With the encouragement of one of our ED docs who worked the night shift, I started experimenting with it and using it to start IVs on patients with challenging veins. However, the use of the new and novel tool was short-lived. Bureaucratic administrators caught wind of what I was doing and quickly put an end to it, as there were no established protocols and an uncertainty of whether my nursing license covered the machine in this scenario. Fast forward about 5 years, and by this time, I've been living in Sierra Leone, West Africa for several years. At the time, the often quoted maternal health statistic was that 1 in 17 women were at some point in their life expected to die from a maternal health complication. At the time, Sierra Leone had the highest maternal mortality rate in the world. I'm not really trained in maternal health, but I'm a systems thinker and often found this issue to be overwhelming. During this period of time, I helped host a medical school professor from the Medical College of Georgia. He brought with him an exciting new tool, an ultrasound probe that could be plugged into a small tablet. Ultrasound technology in a relatively short amount of time had taken a tremendous leap. It was no longer a device contained to a single room or even a wheeled device that could be carefully moved throughout a department. Now the device could be easily transported all over the world in a small backpack. Also, the price point for the machine had suddenly become a lot more affordable. That week, in a short amount of time, the medical school professor did an incredible amount of imaging, looking at livers, lungs, abdomens, eyeballs, and even a few orthopedic injuries. He quickly convinced me that portable ultrasound was the diagnostic future of global health. My organization even purchased a device. However, we quickly encountered a major problem. The training requirements to operate the device were intense. We did have community health officers who started performing basic obstetric ultrasound scans and with time became decently skilled at it. However, when you have a staffing turnover, what happens? You're essentially back at square one. After 5 years of living in Sierra Leone, I returned to the United States. I was finishing up a graduate degree in international development and started interning with a leprosy-focused global health nonprofit. Within days, I was handed a research paper theorizing that portable ultrasound might be the key to subclinical diagnosis of leprosy, as peripheral nerve thickening happened to be one of the cardinal signs of leprosy. I was tasked to identify which companies were manufacturing portable ultrasound machines with the ability to assess peripheral nerves, investigate the price of the machines, and come up with a recommendation for a pilot study. As I looked into this, the limitation that kept tripping us up was the human skill factor. In order for this to be a viable, wide-scale diagnostic tool, it would need to be used more broadly than by a few expertly trained ultrasound professionals. At that time, I started asking the question, could AI solve this problem for us? I finished up my internship believing that AI could solve this problem, but unfortunately, even today, I'm not aware of anyone tackling this opportunity specifically related to leprosy. These key experiences of being exposed to bedside ultrasound use in the emergency department Seeing a well-trained individual doing an incredible job of leveraging the tool while working in global health, realizing that duplicating this ultrasound use was very difficult due to the need for a lot of training, seeing high maternal and neonatal death rates in Sierra Leone, and finally exploring how ultrasound could be used to diagnose subclinical leprosy created an ideal environment for dreaming about new ways of using ultrasound in global health. At some point, through the power of social media, I stumbled upon reference to some of the early work of the BabyChecker device in Sierra Leone. I was immediately fascinated. This device appeared portable, affordable, and also seemed to circumvent the need for specialized training. In early 2022, I reached out to Enya via LinkedIn to learn more, and was honestly a little surprised with how quickly and how warmly she responded. It was a bit of a process, but eventually I was able to get both approval and funding designated that would allow Jericho Road to start using this technology in our clinics in Sierra Leone. Our antenatal attendance rates have increased as patients love the reassurance and novelty offered by the scan. Recently, we were reporting out our antenatal numbers to a maternal health donor. They were surprised at these rates. In preparation for today's talk, I checked in with our nursing and midwife team in Sierra Leone to get firsthand stories about how they've been using the device. They shared the following two stories. At the beginning of August, a woman presented to our regular antenatal clinic for a visit. During the exam, they palpated that the baby's lie was not cephalic and that her belly was very large. They decided to use the BabyChecker device, which estimated gestational age of 40 to 42 weeks. The scan confirmed a breech presentation and a low-lying placenta. The device recommended referral to higher level of care. They carried out this referral, and the lady was sent to the local government hospital. Upon further examination, they identified that the mother was carrying twins. They were able to successfully conduct a C-section. Today, the babies and mother are all doing very well. At the end of September this year, a pregnant mother presented to one of our remote clinics with new onset vaginal bleeding. Fetal heart rate was still present, and so they conducted a BabyChecker scan. The device estimated a gestational age of 35 to 36 weeks and identified a low placenta. The patient was immediately transferred to the government hospital for an emergency C-section. The mother was soon diagnosed with placenta previa. Thanks to early interventions, the mother and child are both alive and doing well today. No mother should die bringing life into the world. On behalf of Jericho Road, on behalf of nursing and midwife teams in Sierra Leone, and on behalf of mothers and babies everywhere, I want to thank Delft Imaging for developing and continuing to refine this product. At the close of this speech, I want to offer up a few audacious challenges. For widespread adoption, how can we get the word out? And how can we make the device radically affordable and the supply chain adequate so that global midwives can, apart from the financial help of governments and nonprofits, be able to both afford and use the device across the global South? How do we move this device from a novel pilot to widespread adoption? Finally, what's next? The application of this device to maternal health is amazing. How else can we develop AI algorithms to help CHWs and community health nurses in local communities perform additional diagnostics related to infectious diseases and beyond? And as an example, I'm imagining a world without leprosy and better TB diagnostics. And I really believe that an adapted tool like this could help accomplish those goals. Thank you very much.